vast array of cuisines. Food is deeply ingrained in our culture and it's a big business.
बड़ा समोसा मूंग भजिया दिन का 1200 के करीब में है ना बिकता है।
आधा किलो मिर्ची यूज करते हैं और लाल वाला भी यूज करते हैं, उससे टेस्ट बहुत बढ़िया आता है सर।
हम लोग हरी मिर्ची और रेड चिल्ली यूज करते हैं, लोगों को वही पसंद आता है।
मुंबई है, भूख की तो कोई समझ नहीं होती है, कभी भी आ जाते हैं, अभी बस चालू रखते हैं।
3 से 4 या 5 बजे तक आते हैं, तब भी उन लोगों को ऑर्डर हम लोग बराबर देते हैं।
In India, food isn't just a fuel, it's an emotion. You don't just eat to live. We love and live to eat, celebrate and share the joy of every bite.
इधर आता हूँ तो मैं बहुत खाता हूँ, एक एक दो दो मैं 4 खाता हूँ, बहुत टेस्टी है।
Unlike in many other countries, in India, burping after a meal is acceptable. Rather, it's considered a sign of satisfaction. Well, we Indians love making all kinds of noises.
मस्त है, बहुत मस्त है, अच्छा है।
The vada pav is amazing.
Beyond dining etiquette, there is a serious concern linked to our love for food. Acid peptic disorders. Symptoms of acid peptic disorders like heartburn, nocturnal burn, and ulcers are on the rise, particularly due to drugs. The increasing prevalence highlights the need for awareness and effective management, especially preventing drug-induced gastritis and GI injury.
In a regular course, Chit Chat is considered a talk about trivial matters. Unfortunately, even symptoms like burping and heartburn are dismissed as frivolous ones, but they can have adverse consequences. Join us as we engage in a highly thought-provoking, scientific evidence-based discussion on GERD management.
Hi folks, ironical, you people, you talk about health and you have guts to line your guts with this kind of street food. How sad, because it is like corollary, a song. सीने में जलन, आँखों में तूफान सा क्यों है, इस शहर में हर शख्स परेशान सा क्यों है. So you invite acidity, GERD, and then you want to solve the problems.
Street food is a part and parcel of our Indian culture.
Right. So तुम्हीने दर्द दिया है, तुम ही दवा दोगे.
In fact, every celebration is associated with the food. We live to eat, not eat to live.
India, it's considered acceptable to burp after eating. In fact, it's a sign of satisfaction.
Only from oral?
Either way, in China it's a reverse.
That's why gastroenterologists are doing well, because Indians are obsessed for food. And there is increased incidence of acidity, acid-related diseases. And adding to it are the NSAIDs, which you use for creating gastritis, ulcer, and so on GI problems.
In fact, gas is a national disease.
Everybody would have suffered from gas and anytime during their lives, So people carry all this acid-reducing drugs in their pockets. After eating everything, just pop in one pill and you keep going. Yeah.
In our hostel days, I remember we would stay up late night looking for food, and we would eat anything we get. Noodles and pav bhaji, whistle pav, whatever you can lay your hands on, cheap food.
Right.
Yeah.
It's irony that we all from the 3 different specialty, orthopedician, physician, gastroenterologist, and we are here discussing about the gut. That shows that the gut plays a main role in our day-to-day life as well as in our practice also.
But that isn't really surprising, because the common factor is drug-induced gastritis. And we all have patients who have to take medication. Us orthopedicians, we use painkillers all the time. We have to dole them out like candy because our patients come to us with pain.
And those all patients come to us with heartburn, pain, vomiting, blood vomiting. So we need to have a balance probably between the protecting the gut from the NSAIDs.
It's very alarming that almost 62% of people taking NSAIDs, they develop all these symptoms. So what's the solution?
and the orthopedicians are not aware of it because majority of the times they come to gastroenterologists. And so we have a good acid suppressive therapy which can be given for long term to protect against NSAID and aspirin induced ulcers. And we have a vonoprazan PCAPS, it is called as potassium competitive acid blocker, which is a new kid on the block, a drug which is more potent, has a rapid action, and lasts for a long time with less drug interaction. And there are trials which have showed that the vonoprazan is equivalent to PPIs in preventing NSAID-induced gastritis, and also is been said to be superior to PPI in preventing aspirin-induced ulcers.
Since you are talking about the aspirin, aspirin is being prescribed by physicians, right, left, and center, for all patients for primary prevention, which is a real big debate. And for aspirin should not be used for patients who have diabetes and hypertension. It should be only used for secondary prevention. So aspirin and clopidogrel are being prescribed by doctors right, left, and center for primary prevention, but these days it should not be used for primary prevention. An aspirin given to all elderly patients can cause upper GI lesions 2 to 4 times higher than the normal population. So you've got to use a real potent drug which will take care of the acid symptoms and really prevent upper GI bleeds. If I was to inquire with you, even 75 milligrams of ecospirin can cause this? Yes. Wow. Elderly people, they should be very careful. And 75 milligrams of aspirin also, for primary prevention, you don't require it at all. Right. It can cause intracranial bleeds also. So remember, primary prevention, aspirin has no role at all. If you have already had an atherosclerotic cardiovascular disease in the form of if you have undergone an angioplasty, or if you have had a heart attack, or if you have had a stroke, but then you've got to prevent a secondary stroke, or then you've got to prevent a second heart attack. Aspirin is absolutely required in such instances. So then they should take with some PPI or vonoprazan.
We prescribe BPI as a prophylactic for all our patients.
Yeah.
We write our prescriptions, we always have a PPI, and yet those patients come back saying we vomited, we have so much acidity, despite the antacid PPI that we write.
So the PPI are slow acting. They take about 3 to 4 days to get relief of symptoms, as against the potassium competitive acid blockers. Vonoprazan is a fast acting. PPI have half-life of 2 to 3 hours, while vonoprazan has a half-life of 7 hours. PPI, they irreversibly bind the proton pump, while the vonoprazan reversibly binds proton pump. PPI requires acid for the activation of for it to act, while vonoprazan doesn't require acid because it directly acts on potassium channel of the proton pump. So vonoprazan is more effective, rapid action, longer duration of action, 70% 24 hours acidity is suppressed by vonoprazan with advantage of less drug interaction.
I would like to add here one more thing about vonoprazan. It's a drug which can be taken independent of your meals. PPIs have to be taken 30 minutes before food or about 60 minutes before meals. This can be taken before or after. We in our practice, we practice diabetes. So we advise them to take all antidiabetics before food. And despite telling all these things, they forget whether to take it before and after. There are lots of confusion. So if you have a drug which can be taken either before or after, independent of meals, the compliance is maintained. Adherence is very good. So you've got to use drugs.
I'll tell you statistics that 70% of physicians and 30% of gastroenterologists were not aware that the PPI has to be taken empty stomach. And in one survey, 50% of the patients were not taking PPI properly. So that was one of the reasons why they were not effective.
If I were to interrupt, actually, when you made a blanket statement that orthopedic surgeons prescribe, but our first drug for preventive aspect of GI upset is PPIs or VONOPRAZAN. Now, I have been writing before breakfast. If it's very high, then because of the half-life, I asked before dinner also. So, vonoprazan, when should I prescribe? What time they should take? If they ask me, what specific time?
Basically, it has to be taken in the morning, independent of meals. So even if you forget before breakfast, you can take it after breakfast because it has a long duration of action of 24 hours. So the half-life is also 7 hours.
That's vonoprazan.
Vonoprazan.
PPIs that we've been using all years.
PPIs have a half-life of 2 hours, 3 hours maximum.
And empty stomach have to be taken.
They have to be taken empty stomach.
Vonoprazan has to be used once daily only. You got 10 milligrams and 20 milligrams available in the market.
Yeah.
So 20 milligrams once daily is good enough.
Yeah, it's 1930s when the antacids were come, and that was a great relief for heartburn, nighttime burning, But you will be surprised that the first randomized control trial of antacids being effective in acid peptic disease was way after 30 to 40 years in 60s and 70s. So it took long time for the scientific evidence to come.
Really, but you see, it gives you a quick relief, but there is no lasting effect of that. So how do you go ahead with this?
Something like putting a temporary plaster or a band-aid for an injury. It's not a long-lasting thing.
So in 70s, after this antacid era, came the H2 receptor antagonists. So they were wonderful drugs in lowering the acid secretions, or they were lowering the acid levels, but they were not totally suppressing it to zero levels. Then came the PPIs.
Yeah.
So these PPIs, they were drugs which will take care of total acid blockade. And they were H blockers, H ion blockers, like potassium acid blockers. Similarly, H ion blockers came in 80s and 90s.
Yeah, PPIs had come in 1970s and they really revolutionized the treatment, whole management of acid peptic disease. And they've been I should not say 70s, I think it is 90s. Because 25 to 30 years they've been there in the market and with significant safety profile. But PPI have some limitations, as I said. They have a short period of action and they have to be taken on empty stomach. And they are associated with drug-drug interaction because they have been metabolized by cytochrome 2C19, which has an interaction with many drugs. So now you have a potassium channel blocker, which is independent of food, rapid acting, long term, and that's vonoprazan.
What about the long-term effect, though it is unfounded, of the PPI, long-term, any side effect?
So actually this molecule is introduced in Japan for the last 10 years. December, to be precise, December 2014. And surprisingly, the long-term data also reveals it's a quite safe molecule. Because when you reduce the acid, you tend to increase the gastrin. Increased gastrin can lead to a proliferation of the cells leading to malignancy. That's a concern. But none of the cases of malignancies have been reported with vonoprazan use
Actually, the
for the last 10 years.
same concern was there with the PPIs also when they were launched.
Yeah.
So
Any interaction with the clopidogrel and the S or
Yes,
omeprazole?
actually that's a good question. The earlier molecules PPI, they used to have an interaction with clopidogrel. As a result, they used to reduce the efficacy of clopidogrel, like omeprazole. But subsequently, the molecules like rabeprazole and esomeprazole were not associated with drug interaction with PPI. But of course, vonoprazan is metabolized by a different enzyme that is cytochrome 2C3A4. So that's a different mechanism of metabolism of vonoprazan.
Even pantoprazole has no drug-drug interactions. Right. So because cardiologists, they prescribe pantoprazole for several years.
The advantage
There is
is
no
no
drug-drug
drug-drug
interaction.
interaction.
What concerns me is that our patients who are taking PPIs or even H2 blockers have to still take antacid tablets, those Gelusil and Digene, and it's like they have to keep taking it. So what is really the problem?
You're right, because with the available PPIs, whatever are there in the market, only about 50 to 60% people are satisfied. So, because of the short action. So, 40% of the people, those who are not satisfied, needs additional drug in the evening or a new molecule. So, vonoprazan is a one, which probably is a one which is a game changer.
What about the using PPI in the morning before breakfast and vonoprazan so that it can take care of the night acid breakthrough?
So even if single dose of vonoprazan takes care of the 24 hours acid, so there is no need of combining PPI with PCAPs. And both have different mechanism of action, so I think there is no need of combination.
That's nice. But in case of severe acidity and other GI side effects, can they work in synergistic method?
So normally, in case of severe acidity, you can ask the patient to take a twice a dose of the same molecule
So
rather
20 milligrams or instead of that 40
20
milligrams?
milligram twice a day.
Okay. Yeah, that's a beautiful idea rather than having two drugs. Yeah, good.
What are the red signs for referring to the gastroenterologist?
Yeah, actually, if you have any patient who has blood vomiting, any patient who has weight loss, any patient who is elderly with burning sensation, short history, elderly person, weight loss, anemia. So these are the patients, those should not be empirically treated and they need to be investigated so that you have to find out what, and then subsequently you can switch
double is
on
not
to
much, yeah,
switch
yeah,
on
that's-
Trying
some.
to move on from those chalky antacids and all those tablets that didn't work on. Yeah, and people were suffering.
At that time, these tablets have worked. Now the situations are changing.
I know treatment has been revolutionized for acidity.
When I was doing general surgery, in fact, in one emergency, I used to operate on peptic ulcer which are burst and perforative peritonitis, and it's like gone. But now today with PPIs and something new kid in the block who has come, vonoprazan, what is the clinical evidence? Can you please elaborate on that?
I must tell you that this was a trial which was conducted in Japan where 640 patients, odd patients were recruited, and this was a double-blind comparative trials as compared to PPI. Both the doses of vonoprazan, 10 milligram, 20 milligram were used as against lansoprazole 15 milligram, and they have shown that the effect is similar to that of PPI. So it was a non-inferiority trial suggesting the benefit of even PCAPs in preventing the NSAID induced GI damage. So this is a large number of patients and it's a double blind trial, so the bias is not there.
So is telling about the efficacy of vonoprazan versus the PPIs, right? So non-inferior means almost similar, if not superior at all. Yeah, and that's good. I mean, it sounds to be good. Aspirin being used for all our cardiovascular disease patients, they are also at a higher risk of GI problems. So we have got a safer and an effective option like vonoprazan, which will really take care of the acidity and all these problems for these cardiovascular disease patients. So vonoprazan is a real good choice.
Yeah. In fact, I must tell you that again there is a clinical evidence that patients who had peptic ulcer, they were randomized to 10 milligram, 20 milligram and a PPI. And the vonoprazan, both the doses were better than PPI in occurrence of recurrence of ulcer secondary to aspirin. So, vonoprazan has a clinical efficacy which has been proven beyond doubt.
And which is superior to PPIs.
This in low dose aspirin, it is superior
So there is a lot of robust evidence in regard of that.
because the drug is there for 10 years in Japan, so that has shown the robust evidence.
Somehow we are lucky because all these things are done and we have 10 years of evidence, so we don't have to do those studies.
US FDA has approved in 2023, and there are trials of these drugs which are there in US to the population also. So where it has also been shown to be effective and better than PPI in many of the conditions.
It's so reassuring that we finally have a drug that is much better than what we were using earlier. Yeah.
And any known side effects, sir, if you are remembering?
See, most of the times the side effects are mainly with the what you get with the acid suppression. So you have more of bacterial infections, GI tract upset, gastroenteritis. These are the common side effects which are seen.
Anything you have seen like SIBO in your clinical practice?
SIBO, unless you give it for a long time, means
What is SIBO?
SIBO is small intestinal bacterial overgrowth.
So you says before giving aspirin, we should use prophylactically this
I
drug.
think in a high risk patient, those who are elderly, those who have comorbidities, those who have history of peptic ulcer, they should be co-prescribed PPI or PCAPs.
But I beg to differ. Aspirin is given to such people only. That means it is mandatory that each and every person, they are diabetes, they have cardiac problem. That's why we are giving aspirin. So every patient needs to be given.
Yeah, indication of
Chances of bleeding
prophylaxis.
is very high with the aspirin.
Yeah,
in the elderly
indications of
people.
prophylaxis are elderly, comorbidities, history of ulcer, renal disease. So these are the patients, those who need it.
But how long can you give then?
It can be co-prescription for a long time because the safety till the patient is taking aspirin.
That means lifelong.
Or our NSAIDs or our famous NSAIDs.
Any word about the pop pill and means as well as requirement? As well as
In
requirement.
fact, I must tell you that because this is such a rapid acting drug, that this is used as on-demand treatment. On-demand means if the patient has heartburn, instead of antacids, he will use this drug which acts in a faster time and relieves the heartburn immediately. This is preferred over and recommended over PPI for such conditions.
I think only word of caution is here. All heartburn need not be because of the acidity. You may have to rule out MI. Yeah. Particularly early morning.
I tell in most of our lectures that once you have burning doesn't say that it is acidity.
No, but only ECG will not show. So you need to do cardiac enzymes as well.
I had this patient I operated for a beautiful apparent humerus reconstruction. Was so happy, started his physiotherapy, did everything so well. Went home the next day. And then there were constant messages that he's vomiting, he has acidity, he has pain in the stomach. I told them, give him this, give him that, give him antacid. The PPIs were going on. Then the son brought him in the night. He was very toxic, lot of pain. Everything was given. And still, the next morning he came to the casualty, vomited blood, and he died. 2 days after surgery. It's so distressing, such an upsetting situation. I just wished that there was something that could have prevented that. What do you think I should have done better?
Basically, he must be having ulcer prior, and the NSAIDs which are used has led to triggered injury and exacerbation of ulcer.
I will also like to share one more case like this doctor's case. My friend who is a radiologist and his father an asthmatic for long time, and he was prescribed an NSAID, and I will tell you which NSAID, and that is piroxicam. He was given piroxicam. It's a notorious drug for orthopedics. I think piroxicam should not be used, although it's very potent. But then my friend called me and he said he has hematemesis. He also has got melena. Oh, and he started bleeding from above and from below. And every day we were infusing 8 bottles of blood to this gentleman. And still we couldn't find where was the bleeding coming from.
Did we have an endoscopy?
It was not possible. Only blood. Colonoscopy, only blood will be seen. Nothing. So we couldn't find the source of the bleed. And ultimately, he had to undergo an exploratory laparotomy. And there was 3 ulcers in the jejunum. And the intestine was to be resected, and it was anastomosed again. And then he came out well. So NSAIDs can be really disastrous. And in particularly, I would like to mention here about piroxicam. Piroxicam is very potent in relieving pain, but then it can cause dangerous ulcers in your...
It's notorious to cause esophagitis.
Even mefenamic acid is a very potent analgesic, but not GI friendly. It's a GI 4.
So the more potent the drug, the more side effects you may have. And they have longer half-life. So the effect stays for longer term. Like meloxicam, you said, 3 days. I mean, you take one today and you'll need after 2-3 days. So people feel happy. So you have to be careful. Even valdecoxib was withdrawn.
Yes.
Okay, let's have a final word from the Dr. Mukewar regarding the...
So what's the takeaway, friends?
So the takeaway is patients who are given VONOPRAZAN is very good and it is a potent drug and sustained also acid relief, particularly in patients with drug-induced gastritis. No, I want to summarize. How did we start? Seene mein jalan. So we have a solution for that. What is the solution? Tum jo mil gaye ho VONOPRAZAN, to ye lagta hai कि जहाँ मिल गया. And for orthopedic surgeons, एक भटके हुए राही को कारवां मिल गया.
So friends, what is the takeaway? Eat spicy pani puri outside, take aspirin and NSAIDs, but remember that protect your gut. And the journey started in 1930 from antacids, 70 H2 blockers, 90s PPI, and now we have a new kid on the block for the last 10 years, 2014, that is potassium competitive acid blocker, VONOPRAZAN, a more potent, rapid, sustained molecule having long duration of action, less drug interaction, preventing NSAID and aspirin.
You're talking a lot, but do you have any evidence of that?
Yeah, the vision trial.
Oh, yeah,
As-
I'm getting the vision now.
For the last 5 years, VONOPRAZAN is supposed to be very safe. Safety has been proved over a period of 5 years. So, it's not that it's a new drug.
Join us as we engage in
A highly thought-provoking, scientific and evidence-based discussion on
Prevention and management of drug-induced gastritis. Let's say in one voice, VONOPRAZAN is the right choice.